Hi, I'm Chao-Wei Hwang from the Johns Hopkins University School of Medicine and Frederick Health Hospital. If you are new to the Cath lab, this video is for you. We are going to talk about the very basics of bifurcation PCI. Okay, you imagine you are in the Cath lab and you overhear two interventionalists having a conversation. And so the patient had a Medina 110 at the LAD diagonal bifurcation. I tried to do provisional, but the gel diagonal was pinched and flow was sluggish, so I ended up doing a tap. Now, if this made complete sense to you, move on and check out another video. But if this sounded like complete gibberish, well, you've come to the right place. Keep watching. So a coronary bifurcation refers to the point where one coronary artery divides into two. Here you see an illustration of a coronary bifurcation with blood coming in from the top. You also see yellow plaque all throughout the vessels. Okay, some basic bifurcation vocabulary. The larger branch of a bifurcation is usually called the main branch, or the main vessel. The main branch can be divided into a proximal segment where blood is coming in from, and a distal segment where blood is traveling to. The smaller branch of a bifurcation is usually called the side branch. In general, interventional cardiologists only worry about side branches that are 2 millimeters in diameter or more. Side branches that are smaller than that are often ignored because they supply only a small amount of cardiac tissue and are usually too small for stenting. Sometimes you'll hear the term parent vessel as well to refer to the proximal part of the main branch. You'll also hear the term daughter vessels for the distal branches, especially if the two vessels are comparable in size. The point in the bifurcation at which the blood vessel divides into two is called the carina. Interventionalists will also often talk about the bifurcation angle. The bifurcation angle refers to the angle between the distal main branch and the side branch as measured at the carina. A large bifurcation angle means that the two vessels are spread wide apart. A narrow bifurcation angle means that the two vessels are close together. Okay, so with this basic vocabulary under our belt, we now need a way to communicate where the stenoses are within the bifurcation. The easiest and most common way to do this is the Medina classification system. In the Medina system, you divide the bifurcation into three parts. The proximal main branch, here referred to as X, the distal main branch, here referred as Y, and the side branch, here referred as Z. Each part is assigned a value of 0 if the stenosis is less than 50% within 5 millimeters of the carina, and a value of 1 if there is a stenosis 50% or more within 5 millimeters of the carina. So a Medina 100 bifurcation would mean that there is a 50+% stenosis in the proximal main branch within 5 millimeters of the carina, but no stenosis anywhere else. A Medina 010 bifurcation would mean that there is a 50+% stenosis in the distal main branch, but nowhere else. And a Medina 001 bifurcation would mean that there is a 50+% stenosis in the side branch, but nowhere else. And here are all the other possible permutations. In Medina 111, there is disease in all three parts of the bifurcation. In Medina 110, there is disease in the proximal and distal main branches, but not the side branch. In Medina 101, there is disease in the proximal main branch and in the side branch, but not in the distal main branch. And finally, in Medina 011, there is disease in the distal main branch and in the side branch, but not in the proximal main branch. Technically, there is also Medina 000, which is a bifurcation without any stenoses that is 50% or more. Now, there are two broad approaches to treating a disease bifurcation. There is non-provisional stenting and there is provisional stenting. In non-provisional stenting, you decide up front that you need to stent both the main branch and the side branch. This is usually when both branches are large and both branches have severe disease. On the other hand, in provisional stenting, you stent only the main branch and leave the side branch alone, unless something happens during the procedure that then requires you to also stent the side branch. So again, this is important to remember. In provisional stenting, you stent the main branch only and leave the side branch alone. Because this keeps simple, provisional stenting is by far the most common and preferred approach for the majority of bifurcation cases. Now, after you stent the main branch, that side branch will now sit behind the wires of the main branch stent. This is called being jailed. In other words, the side branch is jailed by the main branch stent. Sometimes after you balloon or stent the main branch, some of the plaque that was originally in the main branch will get pushed out into the side branch. This is called plaque shifting. If you get enough plaque shifting from the main branch into the side branch, you can create a severe new stenosis at the ostium of the side branch. This is called being pinched. Here you see the ostium of the jailed side branch now pinched with all the shifted plaque. And if you end up severely pinching the side branch after you stent the main branch, well, that's when you need to end up treating the side branch. Hence the word provisional. Again, in provisional stenting, you stent the main branch only and leave the side branch alone, but there's a big red asterisk to that. You may end up also needing to stent the side branch if you create a new severe stenosis in the side branch after stenting the main branch. So there are some basic rules for when you need to treat the side branch. First, as we discussed earlier, we tend to only care about side branches that are 2 millimeters or more in diameter. Side branches that are smaller are too small for stents and usually supply only a very small amount of cardiac tissue. So when do you need to treat that side branch? Well, if it becomes newly occluded or if flow in the side branch becomes sluggish, you'll almost certainly need to treat the side branch. Next, you'll probably also need to treat the side branch if flow is normal, but the patient is having new chest pain or new ischemic ECG changes. You might need to treat the side branch if the new stenosis is 70% or more, although that by itself is actually a soft indication, especially if the patient is not having new chest pain and if flow is normal. Doing FFR of the side branch is sometimes useful to help make the decision in these situations. Now, even if you decide that the side branch now needs to be treated, it does not always mean that you have to put a stent there. That's because balloon angioplasty can do the trick sometimes. Here, you'll often hear the term kissing balloon angioplasty. That means that two balloons are inflated at the same time, one in the main branch and one in the side branch, to flatten the shifted plaque. But why do you have to inflate the balloons simultaneously? Well, because if only the side branch is ballooned, the plaque can shift back from the side branch into the main branch and recreate a stenosis there. Inflating balloons in the main branch and the side branch at the same time minimizes this back and forth shifting of plaque. All right, well, this should be old hat for you by now. In provisional stenting, stent the main branch first, and then stent the side branch, but only if necessary. But how exactly do you go about stenting that side branch? Well, great question. We'll get to that after the next segment. Okay, let's now talk about the other big approach for treating coronary bifurcation disease, non-provisional stenting. So remember, in non-provisional stenting, you've decided up front to stent both branches. And there are several reasons you might want to do that. Usually the side branch is bigger, typically 2.5 millimeters in diameter or more, and there is severe disease close to the ostium or proximally in the side branch. You might also do non-provisional stenting if the bifurcation is severely diseased or if there is a lot of thrombus that can shift back and forth and clog up the side branch. If you end up dissecting that side branch after predilation, you'll usually have to go in and do non-provisional stenting. And finally, you might decide up front to do non-provisional stenting if losing the side branch would be catastrophic, such as losing a large dominant circumflex in left main bifurcation stenting. So non-provisional bifurcation stenting is most commonly seen for the left main LAD and circumflex bifurcation. But it's sometimes also seen in bifurcations of the proximal LAD and a large diagonal branch, or in bifurcation of the proximal circumflex and a large obtuse marginal branch. And unlike provisional bifurcation stenting, where the main branch is stented first, in non-provisional bifurcation stenting, the side branch is usually stented first, and then the main branch stented second. Now, there are a lot of non-provisional stenting techniques that we've come up with over the years, and you'll hear a lot of these terms being thrown around. SKS, V-Stenting, T-Stenting, crush, DK crush, culotte. What do these all mean? Well, we'll talk about some of the most common stenting techniques next. The most straightforward non-provisional bifurcation stenting technique is SKS, or simultaneous kissing stents. This involves placing both stents together at the bifurcation and inflating both of them at the same time. You'll need at least a 7 French guide to be able to pass both stents at the same time. SKS is very easy and very quick, but there is a big drawback. You will end up with a large metal neocarina in the middle of the parent vessel, which will make passing any wires into the distal branches for any future PCI very difficult or nearly impossible. And for this reason, SKS, at least in the coronaries, is usually only reserved for emergencies or for bailout situations. A variation of SKS is V-Stenting. Here, the two stents just touch at the bifurcation without creating a metal neocarina. You can place the stents one at a time, but you'll need a 7 French guide or larger if you wanted to deploy both stents simultaneously. The obvious drawback in V-stenting is that it is only for Medina 011 bifurcation lesions. In other words, disease only in the side branch and in the distal main branch. You're not going to be covering the parent vessel. Next, we have T-stenting. In non-provisional T-stenting, the side branch stent is deployed first and is followed by the main branch stent, which then jails the side branch. T-stenting is also pretty easy to do, but the drawback is that the bifurcation angle really has to be pretty close to 90 degrees. If you try to do T-stenting when the bifurcation angle is not close to 90 degrees, you will leave a segment of the side branch ostium not covered with a stent. That uncovered segment will get bigger as the bifurcation angle gets further away from 90 degrees. Next, there is crush stenting. In non-provisional crush stenting, you deploy the side branch stent first, but sticking out a little bit into the main branch. The main branch stent then goes in, crushing the proximal part of the side branch stent against the wall of the proximal main branch vessel. Cross stenting techniques are by far the most common bifurcation stenting techniques. And that's because they are very versatile and work with all bifurcations. They are not limited by bifurcation angles and do not create a metal neocarina. However, a drawback is that you will end up with 3 layers of crushed stent material in the parent vessel near the ostium of the side branch. Crush stenting actually consists of a family of related techniques, which include classic crush with kissing balloon inflation, mini crush, modified mini crush, DK crush, and nano crush. I go over each of these techniques in my video on called the 6 levels of crush. You should check it out if you want to learn how these techniques came about and how they are done in more detail. Now, of all of different crush techniques, by far the most popular these days is double kissing crush or DK crush. I've made 2 videos on how to do DK crush step by step, and you're welcome to check those out. And finally, there's Culotte stenting. In non-provisional Culotte stenting, again, the side branch stent goes in first and is fully inflated, protruding well out into the main branch. Next, you pass the main branch stent through a stent cell of the deployed side branch stent and then inflate it. So in the proximal main branch, you will essentially end up with the proximal part of the main branch stent deployed concentrically inside the proximal part of the side branch stent. And like crush, Culotte also works for all bifurcation angles. And unlike crush, you won't end up with 3 layers of crush stent material. However, one limitation is that the diameters of the main branch and the side branch must be reasonably similar so that the proximal parts of their stents can be stretched to the same diameter. Culotte can be fairly difficult to do well, and if you're interested, check out my video on this channel on how to do Culotte bifurcation stenting. Now, sometimes you hear interventionalists talk about something called POT when they talk about bifurcation stenting. What the heck is POT? Well, usually after both stents are placed, you'll do kissing balloon angioplasty to dilate both stents well. But 2 balloons inflated together can distort the proximal part of the stents. So interventionalists will often use a short balloon to reshape and re-round the proximal parts of the stents. This is called the proximal optimization technique, or POT. Okay, so at this point you should already be pros at non-provisional stenting techniques. Let's go back to provisional stenting for a minute. Remember, in provisional stenting, you stent the main branch first and stent the side branch only if you have to. But what are the techniques to stent that side branch when you end up having to do it? Well, as it turns out, the techniques are basically the same as the non-provisional stenting techniques, but just done in reverse. There is reverse T-Stenting. So in provisional stenting, that main branch stent went in first, and then the side branch stent then goes in second if needed. There is reverse crush stenting. Again, that main branch stent went in first. The side branch stent then goes in through the main branch stent and is then crushed inside the main branch stent by a balloon. So that means that in reverse crush stenting, the crushed side branch stent struts are inside the main branch stent. In regular non-provisional crush stenting, the crushed side branch stent struts are actually outside the main branch stent and directly against the wall of the vessel. There is also a reverse Culotte stenting. Again, that main branch stent went in first. The side branch stent is then passed through the main branch stent and inflated inside the main branch stent. So again, that means that in reverse Culotte stenting, the proximal side branch stent is deployed inside the proximal main branch stent. This is opposite from regular non-provisional Culotte stenting, where it is the proximal main branch stent that is deployed inside the proximal side branch stent. And leaving the best for last, there is T-end protrusion, or TAP, probably my favorite bifurcation stenting technique. Now, TAP is actually a variation of reverse T-stenting. In TAP, after the main branch stent goes in, you're going to protrude the side branch stent just slightly into the main branch stent before deploying. This ensures that you won't get the gap in side branch ostium stent coverage like you would in T-stenting if the bifurcation angle is not quite at 90 degrees. TAP is easy and it's quick to do. However, it still only works best for larger bifurcation angles, generally 60 degrees or more, and you will be left with a neocarina. That neocarina is usually quite small if the bifurcation angle is larger, and it is usually small enough that it's not a problem passing wires in the future. If you want to learn more about how to do TAP, check out my 2 videos on TAP stenting in which I go over the technique in detail. All right, so that concludes our whirlwind trip through bifurcation PCI. Feel free to check out my channel for more detailed how-to videos on some of the bifurcation PCI techniques that we just talked about. Thank you for watching.